I think we're just about ready to get started. Well, good morning, everyone. Oops. Yeah, I'm unmuted. And welcome to our Medicine Pediatrics Grand Rounds. I have the pleasure of introducing our Grand Round speaker, Dr. Daniel Diekema, who is a adult infectious disease specialist from the University of Iowa. Dr. Diekema is a native Michigander and was born in Lansing, Michigan, and attended and graduated from Calvin College on the west side of the state, where I was in school on the east side of the state. And he then graduated from Vanderbilt Medical School, obtained a master's degree in preventive medicine from the University of Iowa, did his residency at the University of Virginia in adult internal medicine, and then actually did two fellowships, one in infectious disease and epidemiology, and a second in microbiology at the University of Iowa. He's currently the division director for infectious diseases at the University of Iowa Carver School of Medicine. Dr. Diekema's research interests include epidemiology and prevention of healthcare-associated infections, the role of healthcare environment in pathogen transmission, and the impact of emerging laboratory technologies on infection prevention, antimicrobial stewardship, and patient outcomes. And also, he is involved in clinical trials of new antimicrobial susceptibility testing methods. In reviewing just superficially the 280 peer-reviewed articles he's published and many book chapters, I think that Dr. Diekema is the ideal speaker for us to have today on the topic of diagnostic stewardship, better testing to improve treatment and prevention. Thanks so much for joining us virtually, Dr. Diekema.
Yes, thank you very much for having me. It's a real pleasure to be here. I actually started my infectious diseases career in Maine, working with a great group, most of whom are still up there practicing, Augie Blenny and Rob Smith and Patty Stogstill, Carol McCarthy. Really a wonderful group to be part of and a great way to start a career. That's seems like just yesterday, but it's been a little while. The caveat that you just heard, I am not a pediatrician. However, my older brother, Doug, is a pediatrician. And so he regularly reminds me that children are not little adults. And I've tried to include at least a couple of, and more than, a couple of references from pediatric literature as well. You can let me know if that goes over. So let me start with my disclosures. I have received research funding from bioMérieux to do clinical trials of new susceptibility testing methods. I've been a consultant for JMI Laboratories, which does antibiotic resistance surveillance, and done some consulting for OpGen and for Inflammatics. These are companies that are bringing forward new technologies in either metagenomics or host response diagnostics, which I'll talk about in a little bit more detail shortly. So over the next 45 minutes or so, I'm going to start with sort of a whirlwind tour of diagnostic stewardship. And so at the end, I'd like you to be able to describe the different phases of testing during which diagnostic stewardship can be practiced, so that you can work with your laboratory and your stewardship teams to improve diagnostic testing. And then the latter part of the talk, obviously, we're all living now in the middle of a pandemic, and I think it's important to talk also about the pros and the cons of different COVID-19 tests and how best to apply them both to diagnose COVID-19 and also importantly, what their role is in the prevention and control of COVID-19. So I'm going to start with a definition. I wrote an editorial a couple of years back with Dan Morgan and Preeti Malani, and we defined diagnostic stewardship as modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. Robin Patel and Farrokh Fang defined it somewhat differently: the appropriate use of laboratory testing to guide patient management in order to optimize clinical outcomes and limit the spread of antimicrobial resistance. But I think the important common theme here is that diagnostic stewardship is not primarily about reducing costs or trying to artificially drive down a healthcare associated infection metric. It really is about trying to improve treatment, improve outcomes, optimize patient care. And sometimes that doesn't mean doing less testing, it just means doing either more focused testing, or in some cases, bringing up novel tests that may actually end up increasing laboratory costs, but nonetheless do the most important thing, which is to improve treatment and outcomes. So diagnostic stewardship seems to be really of increasing interest lately. You can see just from a few screenshots here, a lot of recent articles on diagnostic stewardship. And indeed, if you look at, just do a PubMed search over time, you can see that over the decade from 2008 to 2018, a real explosion in the number of articles that address diagnostic stewardship. So why is this? I think there are at least three important reasons. The first is that there have been just a lot of technological advances in infectious disease diagnostics, and that's really, you know, we can talk more broadly about diagnostics, but my focus obviously is going to be on infectious disease diagnostics, but there have been some real advances, new tests that are available to us that are faster, more accurate, in most cases more sensitive than conventional diagnostic testing, and a wider array of options that are available. Some of these available at the point of care, and some of them are quite expansive, meaning that they are what we've called sort of unbiased diagnostics in the molecular area, like metagenomics, where you're actually interrogating a sample for all the genetic material that might be present and trying to find that signal that might be associated with the pathogen. So whenever when you have this increased array of tests available that are much more powerful, it becomes a real challenge to make sure that you're employing them the best possible way that you can. The second, I think, reason that diagnostic stewardship is gaining increased attention and focus is because of the rise of antibiotic stewardship. As we know now, every hospital has to and should have an active antibiotic stewardship team. This is a Joint Commission and CMS requirement. And antibiotic stewardship is really very closely tied to diagnostics. The diagnostics are really the lever that in many cases the stewardship team can use to improve the use of antimicrobials. And then lastly, I think a lot of it's undeniable that a lot of diagnostic stewardship is also driven by progress in healthcare associated infection prevention. As you all know, now there's not only public reporting, it has been for a while, but there's pay for performance. So some of the, really most of the healthcare associated infection metrics that we report to CMS and that really do affect the bottom line now for hospitals are based solely on a laboratory test. The C. difficile lab ID event is probably the best example, where just that positive test alone and the date of admission for that patient really define whether you have that, whether you meet that HAI definition. And so labs are under a lot of pressure then to say, are you doing testing optimally so that we're not finding signals that trigger an HAI event that actually don't represent true infection or true disease. So now let's turn to sort of how we do diagnostic stewardship and what opportunities exist to improve diagnostic use. So this slide really gives you how laboratorians think about the diagnostic process. It's a fairly complicated process overall, and extends from the time that a clinician or healthcare personnel decides to order a test all the way to the time that they make an intervention based upon the results of that test. And we divide that process into three major phases: pre-analytic, and that encompass everything from the ordering, collecting, and transporting of that sample to the laboratory, to the analytic, which is the processing and testing of that sample, and then the post-analytic, which includes the interpretation, the reporting, and then most importantly, whatever intervention is going to be made based upon the results of that test. And so the reason it's important to understand the diagnostic process as a whole series like this is that you can change one aspect, and the one that we often focus on is the test itself. Okay, let's bring in a new rapid test for X, and that will really improve our ability to diagnose this infection and treat the patient. But if all you pay attention to is changing the test, but you have problems in the post-analytic arena in terms of interpretation, reporting, or intervening, or you take a rapid test and batch it every day or something like that, then just bringing that new test into the laboratory isn't going to have the impact that you might have hoped. So now I'm just going to cover very briefly some examples of diagnostic stewardship interventions that occur at each of these three major phases: the pre-analytic, analytic, and post-analytic. So starting with pre-analytic test ordering, the major interventions here include educational campaigns and often employing computer decision support to try to focus testing. And I would say the most common areas that labs employ these strategies are to improve C. difficile testing. For example, we have a computer decision support approach where there's a hard stop on C. difficile test ordering. If a patient has had a laxative within the prior 48 hours, hasn't had more than 3 loose stools per day, as a couple of examples of a computer decision support, or has had a negative test within the prior 7 days. There are also many such approaches to try to improve urine culturing. And the goal really of most of these pre-analytic interventions is to focus our testing on a population that has the highest pre-test likelihood of the disease in question. This will reduce the number of potential false positives that you're going to be seeing, and thereby reduce inappropriate antibiotic use, et cetera. Pre-analytic approaches can also encourage more timely testing. So best practice alerts, for example, that might encourage you actually to get a C. diff test if there's diarrhea noted early on during hospitalization. This is becoming important for the healthcare associated infection metric for C. diff, because if someone comes into the hospital with diarrhea or develops it within the first day or two, and you do that test in a timely manner at that time, it will not be included as a hospital onset C. diff infection. If the testing is delayed by 3 days or more from the time of admission, then it will, because as I mentioned, that HAI metric is really based solely on a positive test and the timing of that test relative to hospital admission. So here's just one example of one of these pre-analytic interventions. I like it because it has a concurrent control group, and a lot of the data in diagnostic stewardship consists of single center studies that have before and after study design. So whenever you have one that has a concurrent control group, it's a good thing. This was by Barb Troutner and her colleagues, and they did this study in 2 VA systems. And the sort of treatment system was a guideline-based intervention based upon IDSA guidelines for when one ought to get urine cultures and when one ought not to get urine cultures in a hospitalized patient. They used an audit and feedback approach that included case-based presentations for clinical teams. And what they found, you can see on this slide, was a significant reduction in the number of urine cultures performed in the intervention VA system compared to the control system. And also importantly, a decrease in the overtreatment or inappropriate treatment of asymptomatic bacteriuria from 1.6 to 0.6 per thousand bed days. So a really successful education-based intervention to improve the use of urine culturing. And there are many, similar such studies that have been published. Another pre-analytic focus should be on the collection and transport of samples. So what I refer to as the garbage in, garbage out situation for laboratory testing. And one area of real importance, I think, because of the importance of bacteremia and sepsis, are to focus on your blood culture practices. Everything you can do to reduce blood culture contaminants, we know will reduce inappropriate antimicrobial use, and in some cases, lengths of stay and other unnecessary testing. And some of the things that you can do to reduce blood culture contamination include really having a well-trained phlebotomy service, which time and again has shown can drive your rate of contamination way down. But there are other aspects of blood culture practice that are also important, including making sure that you get the right volume of blood for culturing. That may be perhaps the most important factor associated with blood culture yield, at least in adults, is getting a sufficient amount of blood in a blood culture. Children, very young children, tend to have higher CFUs per ml when they're bacteremic, so lower volumes can suffice for that for younger children, but still making sure that you fill that blood culture bottle to the point that that is recommended will improve your blood culture yield as well. So you'll get fewer false negatives. And then, of course, every clinical microbiologist really hates swabs, situations where there's either a collection of pus or infected tissue that could be sent to the microbiology lab, but instead someone sticks a swab in it or runs a swab over it, which really decreases your yield. So sending as much sample as you can to the micro lab, swabs that are of things like chronic wounds or samples taken from drains, which are really much more likely to identify colonizing flora rather than actual pathogens. So trying to decrease those practices. And then finally, careful tracking of how we handle and transport samples to reduce delays to the laboratory. If you're collecting urine sample, for example, that doesn't have boric acid or other additive to prevent bacterial replication, if that urine sample sits at room temperature for a couple of hours, we know bacteria replicate every 20 minutes. So you can easily end up with a falsely positive urine culture just because of a delay in transport or lack of refrigeration on the way to the laboratory. And then I mentioned earlier some of the really powerful diagnostic tools that we're starting to see come to the fore, like metagenomic testing, which really interrogates all the genetic material in a sample. These really sensitive tests make pre-analytic variables at least as, and probably more important, because unfortunately, well, not unfortunately, but we live in a world of microbial life. So there's microbial DNA basically everywhere. So if you're doing a very sensitive metagenomic test, you can end up detecting genetic material that's inside a collection container. And so some of the studies that I think are going to be increasingly important as we move some of these genetic tests in metagenomic tests forward are studies like this that look at the impact of different kinds of collection tubes, of time to transport to the laboratory, processing delays, et cetera, in yield. And that's going to be important as we think about moving these to routine laboratory use. So now let's move to the analytic phase where the sample is in the laboratory. Every lab should have screening and rejection policies for different samples. So most labs will reject a sputum culture, for example, if there are more squamous epithelial cells than neutrophils, to reduce the workup of oropharyngeal colonizers that really are not pathogens. Many labs are also introducing screening criteria for urine cultures, so-called reflex protocols, where they will only culture the urine if under the microscope you can see white cells present. Obviously, this wouldn't be applied to patients, for example, who are neutropenic. But in general, these reflex protocols have been shown to reduce urine culturing and unnecessary antibiotic utilization without having negative consequences in terms of missing urinary tract infections. And then another simple approach that pretty much all labs take now is they will not do C. difficile testing on stool that is not liquid, or in our lab that doesn't conform to the container, because we know that with these very sensitive C. diff PCR tests, that there are a lot of people walking around with toxigenic C. difficile, but who do not have C. difficile disease. And the data would suggest that anywhere between 10 and 15% in some studies of hospitalized patients will have a positive C. diff PCR if you send a stool sample or perirectal swab to the laboratory, regardless of whether they actually have disease. So then, obviously, a really important part of the analytic phase of testing is what test you choose to employ, and sort of maybe some of the most important movement in diagnostic laboratories over the last several years is to adopt rapid testing in an attempt to improve antimicrobial use and outcomes that can detect, for example, the organism causing bacteremia. What is that organism? What is it susceptible to? Try to reduce the time to identification and susceptibility test results. Another is to do rapid screening for certain multiply drug-resistant organisms like MRSA, so that if someone is not carrying MRSA in their nares, the likelihood that their pulmonary infection or pneumonia is due to MRSA is less, and you may be able to then reduce vancomycin use. So there are a lot of these approaches, and I'll talk in more detail about them. It can also include modifying your test algorithm to improve the specificity of a test. So as I alluded to before, the C. diff PCR, which detects the toxin gene, is extremely sensitive. And when it was adopted by many laboratories several years ago, they saw their C. diff rates go way, way up, and soon realized that they were detecting a fair number of people who were simply carriers of toxigenic C. diff, didn't actually have disease. So now you're seeing the pendulum swing the other way, where laboratories may be adding back a toxin EIA test to look for the presence of toxin itself, not just the toxin gene, to try to help adjudicate whether a patient has active disease due to C. diff or is simply a carrier of C. diff. This is not perfect, but it can add to the specificity of that test. And then whether, and I won't be covering a lot about host response diagnostics, but this is another, test selection issue. We have not used procalcitonin at Iowa, but other hospitals certainly have found that combining procalcitonin with active antimicrobial stewardship can help reduce the duration of antibiotic use particularly in ICU environments. So just here's one example of, during the analytic phase, choosing a more rapid test. So this was done at CHOP, a single center prospective interventional study where they adopted a multiplex PCR panel for testing of all positive blood cultures. And this was a panel focused on gram-positive cocci. So if the blood culture in the child turned positive for gram-positive cocci, then they would immediately do this rapid multiplex panel, which gave the organism ID and also some information about susceptibility, like whether, if it was Staph aureus, whether it carried the MEK-A gene and was MRSA. And they looked at whether this more rapid test reduced the time to effective therapy and reduced the time to stopping vancomycin in those patients who didn't have MRSA or MRSE. And they coupled this, importantly, with antimicrobial stewardship. And I'm just showing you part of their results, but you can see that there was about a 16-hour reduction in the median time to optimal therapy for the children with a positive blood culture. And this optimal therapy included no treatment of children who were felt to have a blood culture contaminant, a coagulase negative staph in one blood culture bottle out of several, for example. Many of these single center studies, before and after studies of rapid diagnostics, are not powered to look at other outcomes like length of stay or mortality. But there have been a couple of meta-analyses, and I'm going to show you one here by Tristan Timbrook and his colleagues. And they did a meta-analysis a few years ago now, looking at over 30 studies of the implementation of a rapid identification or susceptibility test on positive blood cultures. So it still requires culturing of the blood, but then as soon as that blood culture turns positive, as opposed to plating it out and waiting for the organism to grow on solid media and doing conventional testing, they would apply these rapid tests directly to a positive blood culture. The definition that they used was it had to be a commercially available molecular test that turned results around in less than 24 hours. Most of them were PCR, nucleic acid amplification tests, like the multiplex panel that I showed you in the previous study. Some were nucleic acid probes. Some were application of MALDI-TOF or proteomic identification directly on a very briefly incubated plate from a blood culture. And they looked at the outcome of 30-day mortality. So hoping that by combining all these pre-post quasi-experimental studies, they could get some indication of whether there was a mortality benefit. And the majority of these had an antimicrobial stewardship program facilitating the implementation of the rapid test and facilitating the eFerrin arm of testing. So the test result, for example, would be paged to the stewardship team, which would then work with either the infectious disease consult service or the primary team to optimize antibiotic therapy. And I'm sorry for this pretty busy slide, but this is the forest plot looking at from this meta-analysis. And what you can see here, the bottom line is that there was a significant difference in mortality at 30 days that favored the rapid detection testing with an odds ratio for mortality of 0.66, so 34% reduction in odds of mortality. But I think one of the important points from this study is that the results were statistically significant and more pronounced when the diagnostic, rapid diagnostic was paired with antimicrobial stewardship, with an active antimicrobial stewardship team. The 95% confidence intervals of the odds ratio estimate overlapped with 1 when they looked at just those studies that didn't include an antimicrobial stewardship program. So I think this sort of emphasizes the importance of an active antimicrobial stewardship program. It also makes it harder to really determine how much of the impact of these interventions is related to the diagnostic being rapid versus the increased ability of the antimicrobial stewardship team to intervene. So just to summarize, the overall odds ratio for 30-day mortality was 0.66, statistically significant only with an active stewardship program, and a pretty small number needed to treat. If you looked at those numbers of 20 for a reduction in mortality. And then it also reduced the time to effective therapy by about 5 hours. Obviously, these study designs are limited, these pre-post study designs, and subject to fair number of different biases and confounders. And as I mentioned before, importantly, it's hard to know how much of the difference was due to the rapidity of the test versus the involvement of antimicrobial stewardship program. So I want to move now to sort of post-analytic interpretation of test results, and focus just for a moment on the issue of when does detection of an organism equal infection? And this is something very familiar to all of us as we look at, for example, the results of C. difficile testing when we find bacteria in the urine. And, you know, over-testing and finding these organisms when they're not a true cause of disease can lead to over-treatment and adverse outcomes. And the reason this is a really important point is because as we do more sensitive, multiplex, and metagenomic testing, we're going to be finding organisms that are present, and without really understanding necessarily whether those organisms are a cause of disease or require treatment. So as we start to see these tests coming online, we need to focus really on clinical validation. You know, laboratory sort of analytic validation is one thing, but validating it for clinical use is quite another. And this also, I think, may open the door to more wide application of more advanced host response diagnostics to kind of pair it with some of the metagenomic data to say we can tell you what organisms are present in this sample, and we can also tell you how the host immune response is evolving, and whether it's evolving in a way that suggests bacterial infection or viral infection or a non-infectious cause of inflammation. So the types of tests that I'm talking about include plasma metagenomic next-gen sequencing. So just to take a moment to make sure everyone's on the same page here, by metagenomics, we're talking about interrogating all the genetic material in a sample. Next-gen sequencing just refers to, you know, faster, the technological advances that make sequencing more widely available and more rapid. So as it turns out now, there are, you know, CLIA labs that will do metagenomic testing, either on different samples, on plasma, on tissue. And this is a report of just one experience with plasma next-gen sequencing in a pediatric population. And let me just see if I can get to the right side here. So what this does is you take a sample from the patient of blood and send the plasma to this laboratory, and they will look at all the cell-free DNA in plasma, subtract the human reads, and look for microbial signals in that genetic material. And so in the 54 patients that were included in this observational study, 29 of them had organisms present at amounts that were considered to be significant by this laboratory. But almost half of them, of these positives, were deemed to be clinically irrelevant by the primary team taking care of the patient. And equally sort of disconcerting was that about half of the negatives were felt to be falsely negative when a full evaluation of the child was completed, including conventional microbiology and clinical course. And the reason I say that's disconcerting is that one hope would be that with a really sensitive metagenomic test, maybe the negative predictive value would be sufficient that you could make significant changes in therapy. But at least in this experience, it was not. And only 8 of the patients had a treatment change based upon the results of the metagenomic testing. About half of these were de-escalations of antibiotics, and about half were expansion of antibiotic therapy. So relatively low yield, and is another example, I think, of how important clinical judgment and pre-test probability is to diagnostic testing. Because, you know, the sort of futuristic sort of science fiction version of advanced diagnostics is that, oh, you can just send a sample to a laboratory and they'll tell you exactly what's going on. When in fact, the more sensitive and the more information that we're provided about sort of the microbial community that exists in a body site in plasma or in tissue, the more important clinical judgment becomes. Because as you can see from, and again, this is from this experience, they thought maybe by using the number of DNA molecules per microliter, they could differentiate what they felt to be irrelevant, environmental contaminating, et cetera, organisms from clinically relevant organisms. But you can see there's a substantial overlap here between the amount of genetic material found for what were felt to be clinically irrelevant versus relevant organisms. And then very quickly, this is just to give you an example. This is an unpublished preprint, but this may be where we're headed eventually with some of this testing. 200 consecutive patients admitted or seen in the Stanford Emergency Department had this plasma metagenomic next-gen sequencing performed, but at the same time, they had the host response profiling. And I think, you know, a few years down the road, if this does become more routine, we'll probably be linking the metagenomics with host response diagnostics. So now, lastly, the interpretation reporting. The major areas of focus here are on selective reporting or cascading of results, like cascading of susceptibility test results to guide clinicians to optimal or preferred therapy, including clear explanations to reduce inappropriate treatment, like this is a likely contaminant, or this patient has a positive PCR for the toxin gene, but no toxin by EIA, so they might be colonized, just to help clinicians interpret the test. And then finally, linking a test result directly to antibiotic stewardship. These things up here, the selective reporting or cascading, and the explanatory comments, I refer to and others refer to as laboratory nudges. And there was a kind of nice review of the effectiveness of laboratory nudges that was published last year in Infection Control and Hospital Epi. And this looked at 15 studies, again, mostly pre-post design. And in a dozen of them, there was a significant change in at least one antibiotic use outcome. Most of these studies reported cascading of susceptibility test results to guide therapy, but there were other interesting approaches, including labs that, for example, didn't actively report urine culture results. They required the clinician to call if they really wanted them. So there are some interesting data on these laboratory nudges, but also importantly from this review, identified a lot of major research gaps that we need to address. And then I'm going to, before I get on to COVID testing, just give one example of a lab nudge that I really like. This was a 4-hospital study, again, a before-after study, where all the laboratory did, so, you know, labs, when they do sputum cultures, they report often commensal respiratory flora or normal respiratory flora. And lab algorithms include making sure that you're not looking at Staph aureus or Pseudomonas in among that normal respiratory flora, because it wouldn't be considered commensal. So they just added a simple comment: no Staph aureus, MRSA, or Pseudomonas to commensal respiratory flora. And again, they incorporated antimicrobial stewardship program and educational intervention to prescribers and pharmacists, and encouraged de-escalation when this comment was present. And when they looked at the percentage of patients in whom de-escalation occurred, it went up dramatically after the intervention, from in the 30s for MRSA and Pseudomonas up to 70%, reduced the duration of anti-MRSA and Pseudomonas treatment by a couple of days, and also saw a reduction in acute kidney injury associated with this intervention. So a simple lab nudge that I think can be highly effective in improving antimicrobial use. So now, for the last 10 or 15 minutes, I want to talk about COVID-19 diagnostics. So I think the main question right now that we're all dealing with is diagnostic stewardship possible or even relevant for COVID-19? I mean, after all, we are in a pandemic. Community transmission is rampant, and we know that pre-symptomatic and asymptomatic shedding and transmission is occurring. So what this leads to is a sort of inevitable expansion of testing recommendations, so that basically you test, as more tests become available, you just test more people, symptomatic or not. But I would argue that you know, we need to consider the fact that testing supplies are limited, and the sort of ongoing expansion of diagnostic testing for COVID-19 has actually limited the availability of other important diagnostic tests, including those for sexually transmitted diseases, for example. A lot of laboratories are running short on the ability to do nucleic acid amplification testing for GC and chlamydia, as just one example. So I think diagnostic stewardship rules should apply even during a pandemic. We should be focusing our testing on those who have the greatest pre-test likelihood of COVID-19, either those who are symptomatic or those who are high-risk exposures, who have been exposed to someone and may benefit from post-exposure testing during a quarantine period. We also need to consider, as we expand testing into asymptomatic populations for prevention, whether we have whether those test results are going to actually impact our response, and whether we have the resources available to respond effectively, as I'll discuss. So first, just to talk briefly about what diagnostic tests are available for SARS-CoV-2. Basically 3 categories: PCR, which detects viral nucleic acid or the RNA of the virus. This has the highest analytic sensitivity, but the limitation is that it can remain positive for long after an acute infection. You know, we have people that are up to 3 months after their acute infection that can still test positive by some of the PCR tests, primarily because patients do appear, even after they stop shedding viable virus, they're shedding respiratory epithelial cells that have RNA fragments of the virus present, and can see a positive test. So that's the PCR testing. The next big category are antigen tests. These detect viral proteins. The most common ones detect the nucleocapsid protein. These have lower analytic sensitivity than the PCR tests, but when they're positive, it's more likely, at least, that there is intact or viable virus present in that sample. And then finally, serology detects the antibody response to the virus, which of course is negative. These tests would be negative in the early viral phase of illness and become positive about 1 to 3 weeks into illness. There are a few caveats here. There are some of the PCR tests, particularly the most common point of care PCR test, the Abbott ID Now, is an isothermal amplification. So it is a NAT test, but it has a lower analytic sensitivity, still probably a bit higher than the antigen testing, but lower than most laboratory PCR tests. So I'm referring to analytic sensitivity because I think it's important to distinguish between the two. Analytic sensitivity, it's a laboratory measurement where we determine how much viral nucleic acid or antigen has to be present in a sample for the test to be positive. This is independent of the clinical situation, can also be expressed as the limit of detection, and you can actually go to a public-facing FDA website to look at the limit of detection for many of the different PCR tests that are available. Clinical sensitivity is different. Clinical sensitivity is saying, how likely is this test to be positive if my patient's symptoms are due to COVID-19? This will vary by the testing type that you're doing, as I mentioned before, but also the sampling site, with probably the nasopharyngeal sample being the gold standard. And most importantly, the duration of symptoms, the timing of the test that's being performed. Because if we look at the course of disease with COVID-19, if you're exposed here and potentially infected, there's about a 5-day incubation period on average before the symptomatic phase begins. And the amount of virus present in the upper respiratory tract reaches its peak possibly a little before the onset of symptoms, but at least right around the time of symptom onset. And then it begins to fall relatively rapidly. So that by days 5 to 7, the amount of virus being shed in the upper airways in most patients has dropped substantially, and so will the sensitivity of the test. So the PCR is going to be positive from a couple days, probably before symptom onset, and as I mentioned, in some cases can be positive for weeks afterwards, whereas the antigen test is more likely to be positive only when the amount of virus is at its peak in the upper airway, which is probably also the peak of infectivity for the individual. And then the serology begins to become positive about a week out, where antibodies are detectable. But think about the clinical course of COVID-19, where oftentimes patients require hospitalization, not during the early viral phase, but during the sort of immune or cytokine-driven phase, which can be 7 to 10 days after the onset of symptoms, by which time the amount of upper airway viral shedding has declined a lot, and you can see a falsely negative both PCR and antigen test. So just a quick comment on serology and when serology might be helpful. I think, as I just mentioned, at the time of hospitalization, we can sometimes see a negative PCR test because the viral load in the upper airway has been dropping. And sometimes serology will be helpful. So if the patient has a high pretest likelihood of COVID-19, is more than a week from symptom onset and has a negative PCR, I will send a serology just to help nail down that diagnosis. We are also, I'm not sure, this is something that I would recommend universally, but we've been screening every hospital admission, as have many people, for COVID-19. And when you do that, you do get these unexpected positive tests. in low pretest likelihood situations. The patient has no symptoms of COVID-19 anyway, and has a positive test on admission. The further we get into the pandemic, the more we're going to be seeing some patients who may be weeks out from their infection, but are periodically having positive tests. And when we look at the cycle threshold value, which is an indicator of the viral load, oftentimes they have very small amounts of detectable virus. So it may represent a remote infection. So we have used it to help adjudicate that as well. And then finally, seroprevalence surveys to define the epidemiology, the number of people in a population who've been infected. And I just wanted to note this to recognize that Maine has really done quite well in the US in terms of its, at least what we're seeing in the seroprevalence studies. This study, which just came out within the last couple of weeks, was a serosurvey nationally, and they found that in Maine, only about 0.5% of the samples showed evidence of prior COVID-19, whereas the peak state was New York, 17%, and in Iowa, we're at about 8%. So this also will tell you that if you start doing universal screening types of approaches, at least in Maine, it's going to be in a low pretest likelihood population. Because if you move from the diagnosis of COVID-19 to using the test in a public health way, then I think it's a very different situation and a different set of questions. So I think it's important to ask, do we want to employ a test as a diagnostic test? Does the patient in front of me have COVID-19? Or do I want to employ it as an infectiousness test? In this population, I want to identify anyone who might be infectious and remove and isolate them. That's a public health intervention. And so there's been a real movement, and many of you have probably read articles quoting Michael Mina, who's sort of become a minor celebrity now in clinical microbiology, because he's pushing for frequent, low sensitivity testing as a means, as a really a public health intervention. And so the concept is here again, where the viral load is at its peak for maybe 5 to 7 days around the onset of symptoms. PCR testing has the highest analytic sensitivity and can detect the virus for a little bit longer than antigen testing, certainly. But for public health purposes, we really only care about finding those patients who are most infectious. And so the concept is repeated use of a lower sensitivity test to identify those individuals during the time they might be infectious, as opposed to using a very high analytic sensitivity test that might be positive even after someone is no longer infectious. And so he has, and others have proposed doing this in a really widespread way, like possibly even daily testing of the US population. The problem though with that is the most sort of widely used rapid antigen test is about 98.5% specific. This would mean that in the US population, you would produce several million false positive tests a day. And in most areas, including in Maine, more of your positives would be false positives than true positives. And so it really requires you to do follow-up testing on all positives, possibly with nucleic acid amplification tests, at least with another antigen test, because of the implications of a positive test. We really don't yet have that capacity, much less the capacity to do rapid antigen testing on everyone. So the assumptions of this repetitive home testing are that we have a rapid, cheap method of self-testing that is sensitive for infectivity, but maybe not for the diagnosis. And then importantly, that we have equal access to this testing across the population. Otherwise, we just have yet another disparity in COVID-19, which is access to testing. And we know that more of the COVID-19 spread is occurring in disenfranchised populations, lower socioeconomic status, people of color that are most affected by this pandemic. So we would need to make sure this testing was available broadly across the population. And then importantly, that contact tracing resources are available. There are many parts of the US right now that have basically abandoned contact tracing as the pandemic has surged again. And then finally, the ability and willingness of the public to adhere to public health guidance. These two graphs are from a really shocking preprint out of the UK, where they did surveys, longitudinal surveys, over 40,000 citizens of the UK, and those who had had a contact and were instructed to quarantine, although 70% or so intended to do so, only about 10% adhered to quarantine recommendations. And similarly, for those known to be infected, only about 20% adhered to self-isolation. So I'm not sure that adding this kind of testing is necessarily going to be the way out of this pandemic. The places where serial testing has been most successful have been on college campuses. And so I just refer you to this report from Duke, where they did twice weekly testing and found that they found more positive tests from their routine testing than from their symptom monitoring. So they probably did interrupt some chains of transmission. And importantly, over half the folks that they found to be positive, with the students or staff, were asymptomatic. But in the end, they did a lot of other things as well, including single occupancy dorm rooms, modifying classrooms, mandatory masking and social distancing, et cetera. And they were during the time of this study, the community prevalence was not terribly high. So it's unclear the extent to which this repetitive testing was key to controlling COVID-19 on their campus. So to finish up, I think diagnostic stewardship is essential as well for SARS-CoV-2, and many of us have been using computer decision support to try to focus testing on the highest pretest likelihood populations, make sure we pay attention to adequate training and for sampling of patients for COVID-19, trying to reduce delays in transport, in testing, in test reporting, and then choosing the right test for the right situation, PCR versus antigen versus serology. And so to finish up, diagnostic stewardship is the process of modifying the ordering, performing, and reporting of diagnostic tests to improve patient care and outcomes. There are opportunities at each stage of testing. It's important that this be team-based, the clinical team, laboratory, pharmacy, and antimicrobial stewardship and infection prevention programs all be at the table to make decisions about how we use diagnostics. And then also really important, we need a much better studies, better evaluation of the outcomes of diagnostic stewardship interventions. So I'm sorry, I went actually a little longer than I thought I would, but I am happy to try to find the chat box and answer any questions.
Would you like me to read the questions in the chat box to you, Dan, or do you see it?
Yes, I can see it now. So we had a question about, would you suggest almost never ordering a urine culture if it didn't reflex to it by lab standards? I recently did on a 5-year-old, and it grew greater than 100,000 of group B strep. Well, I mean, in general, I do, there are certain situations when we would want to do urine culturing. For example, you know, although this is still now a little bit controversial, in pregnancy, where you would treat asymptomatic bacteria before urologic procedures, where you would want to know if there were if there was urinary tract colonization before you did an invasive procedure. In a renal transplant patient, you may do so. And then in a patient with neutropenia who can't develop a white cell response, those are situations where you would go ahead and do that urine culture despite the fact that you didn't see white cells on a microscopy. A question about nudging. So nudging is really, it's sort of a, I guess, sociological or social psychology term about sort of making it easier to do the desired thing or the right thing, and it's by basically only presenting the options that you think optimize the response to that diagnostic test. So, for example, if you have a CSF culture that's growing pneumococcus, even though that pneumococcus might be susceptible to a first-generation cephalosporin, you're not going to show that as an option because you want to nudge the clinician towards a antibiotic that actually crosses the blood-brain barrier. I mean, that's a more extreme example. And let's see. I like the idea of supplementing a C. diff PCR positive test with a toxin test to identify colonized without active. Ordering both in every patient can get expensive. Do you have any suggestions on how to effectively apply the toxin test as an add-on? So what we've been doing is we've switched our algorithm now. So we do the PCR test on all the samples, and we only apply the toxin EIA on those where the PCR is positive. This is more costly than the algorithm that we previously used, which started with a glutamine dehydrogenase and toxin EIA, and then only did a PCR on those tests where we had a positive GDH and a negative toxin EIA. So I think more and more labs are going to this reversed algorithm where they do the PCR test first and then the toxin EIA on the positives. In some cases, basically because it will reduce your C. diff standardized infection ratio if you take that approach. And then another question about the Abbott, about the ID Now. So the ID Now, so there's a Binax Now test that is an antigen test. So that's the popular, that's the card-based antigen test, is the Binax Now. The Abbott ID Now is a point of care instrument that does nucleic acid amplification. It does what we call isothermal amplification. So it's able to do, the technology does similar to PCR, but without requiring the repeated changes in temperature that PCR technology is based upon. Isothermal amplification tests, whether it's for influenza or SARS-CoV-2 or whatever, in general have lower analytic sensitivity than standard PCR tests. And I should say that there are now some point of care SARS-CoV-2 PCR tests that are basically similar in analytic sensitivity to what you would get with what you would get in your central laboratory. All right, I think, those are all the questions that I see.
I think you have some in the chat box.
Okay, there's a box called Q&A, let's see.
And then there's a chat as well. Can you see those?
Oh, yes, yes. Oh yeah, there's more here. Okay. What are your thoughts about antigen tests in asymptomatic people, such as what Michael Mina has suggested, routine rapid testing, get people back to school and work? And so I kind of alluded to that in the talk. I think in a perfect world, that would be one of the many kind of layers of Swiss cheese that we need to do to get this epidemic under control. But for some of the reasons I mentioned, I think right now it's not practicable. First of all, we don't have, warehouses filled with highly specific rapid antigen tests that are ready to be deployed. And in order to deploy them, we really need to have all the contact tracing resources in place. And we have to have the ability to do what people refer to as the orthogonal testing, the follow-up of the positives, because a false positive, which will in most locations outnumber true positives, can have dire consequences for people if they need to self-isolate for 10 days. Some people can't do that. They'll lose income or they'll lose their job. So we really need to make sure that we have the ability to do backup tests, because I think when you apply these antigen tests, any of the antigen tests to asymptomatic populations, you have to either repeat the antigen test or repeat a PCR test for the positives, at least those asymptomatic positives. I suppose if you're in a community where you really had really high community rates of infection, you could revisit that, but that doesn't, those would be sort of like what we had in Iowa a couple of weeks ago, where 30% of our tests were positive. Let's see here, I answered that one. So this is an important point, which illustrates the fact that I'm not a pediatrician. For urine culture, would add that infants can have a normal UA, but positive urine culture. UA dipsticks are positive on those that can hold their urine for 4 to 8 hours. So yeah, this is more, much of what the data that I presented on the urine culture testing is from data in adult populations. COVID antibody, is there any knowledge about how long the antibodies remain positive after known infection? Yeah, we are learning more about that, and it does look like most people have a fairly prolonged antibody response, or at least the antibodies are detectable for several months, at least 5 to 6 months in most of the patients, or most people that have been tested. However, there definitely are some folks who have either lack of antibody response or a decline in antibody titers to below detectability. And those tend to be those who have minimally symptomatic or asymptomatic infections, may not have quite as robust an antibody response. But it's also important to note that there's some cell-mediated immunity as well that's important, and anamnestic responses that can occur. So it's not clear. I think one of the things that we're all very interested in is how antibody tests will be used as we move forward into the vaccine era, and which antibody tests or how antibody positivity relates to the presence of neutralizing antibody. Most of the the serology tests do detect antibody against the spike protein, which seems to be, the important target, at least for vaccine development. Some of the serologic tests, though, do target the envelope protein. So you have to know like what serologic test you're using as well. But I think that the duration of immunity data that's coming out has been, by and large, pretty encouraging. That immune responses are going to be pretty durable. But we're early in the pandemic, so we really only know in a 6 to 12 month window at this point. Okay, I think I answered. If others have questions, or maybe I've got. Okay, I think I've answered everything. It's been a real pleasure. It's always a little weird to talk at a screen for an hour. So thank you so much for your attention, and I've really enjoyed it.
Thank you so much.
Thanks, Dan.
All right.